I'm very excited about today's topic. As soon as I read their paper, Creating Positive Spaces for Culture of Humility, so we need to hear from Rosemary and Ben. I also want to mention that there is a book draw, like every single round, so we have a book. Today's book is Braiding Sweetgrass, and it's a beautiful story of how Indigenous people view the world around us. And I feel like there is a lesson in every single page or every single chapter, but it doesn't read that way. It reads more as a story of learning about plants, animals, and how can we take care about the earth, and how can we express our gratitude to the land. So let me just introduce the speakers today. Thank you so much. We have Benjamin Carroll. He's a PhD student at Queen's University School of Nursing, educator at the University of Ottawa, registered nurse, pediatric surgery, nursing education. His research interests are integrity and self-concept in the healthcare environment, past research, examination of nurse practitioner attitudes in caring for transgender clients from a cultural humility perspective. And he was the recipient of a 2017-19 CIHR Knowledge Translation Trainee Award for Innovative Thinking to Support LGBTQI2SHealth and Wellness. And we also have Rosemary Wilson. Rosemary, is an associate professor in the School of Nursing, Department of Anesthesiology at Queen's University, and a nurse practitioner in chronic pain care at Kingston Health Science Center. She has been a nurse for 25 years and a nurse practitioner since 2000. Rosemary is also the Associate Director for the Graduate Nursing Programs and the Deputy Director for the Practice for the Queen's Collaboration for Healthcare Quality. The work that she does there includes the generation of knowledge synthesis and translation for practice, and her research centers around acute and chronic pain that spans from pluralist, clinically oriented research to knowledge translation and quality improvement. That's a lot for both of you. Thank you for doing all that, and thank you for presenting on today's topic, which I think is so important. Okay,
thanks.
It's all yours.
Thank you. I'm really excited about the book draw, even though I don't think I'm eligible, but the topic of indigeneity and decolonization is intimately connected with cultural humility and its outcome, cultural safety, and I've kind of woven some of that in there, and I have extra slides if anybody has any questions about that connection, because I think it's really important for health, both medical, nursing, physio, occupational therapy, education in Canada, for us to prioritize First Nations experiences in this as well. And in so doing, recognizing that we're gathered today on Haudenosaunee and Anishinaabe First Nations territory, and they're the keepers of this land, and we share this land and our paths forward on it. So thank you for the lovely introduction as well. And I just have some objectives here as well. I'm going to start out just by talking about some of the queer spaces and looking at sexual orientation and gender identity definitions, talking about some of the health implications of that for people who move through those spaces, and then talk about cultural humility as a key concept to destigmatizing and thoughtfully situating people with diverse sexual orientation and gender identities. And then looking at key educational resources, and then if there's time, looking on into innovative tools and research, ethics, that kind of thing. The terminology piece, this is also an excellent book for future draws. Queer and Trans Voices in Healthcare, it's a Canadian book, and it's a lot of first-person narrative stories. And in there's a quote from a person who's a social worker and works with youth that basically they're saying if we lose the ability to connect and therefore do effective work with our young people, we're not doing our job. And so we need to keep up with the language and the lingo, and it's fast moving in online environments and with young people who are seeking their own identities and want to be unique and different. And sometimes that's just by naming themselves differently. So some of the terms that I'm going to mention are kind of passé in some respects, even already with a lot of young folks, but in the overall literature and body of knowledge, they're still current. So heads up if you're working with client populations, they might not be using some of these if they're young folks. Just a really quick refresh. The gender unicorn's an excellent tool to use with clients in helping to disambiguate some of these terms if they're, or with undergraduate students, if they're not really familiar with the difference between sex and gender. So sex assigned at birth is the doctor holding you up and saying, oh, it's a boy or it's a girl kind of thing, or the midwife or whoever. And sometimes, of course, there's infants born with ambiguous genitalia who might fall into a category of intersex, or in the clinical literature now, it's disorders of sex development is what everybody who's intersex is classified under for urology and gynecology and that kind of thing. And so those two names move through the literature and make some of the research possibilities a bit difficult. And then gender is what you think, so that little rainbow with the coming out from the unicorn there, how you feel in your body about the gender that you are. And a lot of gender stuff is defined by our society and culture, how we're brought up, that kind of thing. And so that may match your sex assigned at birth, at which point, you know, you're a cisgendered person, if those two things match for you. If they don't match, then you might be considered trans if you think that's something you need to really take action on. If it's something you just sort of hold on to for yourself, you might be non-binary. Non-binary can include trans folks. So some of the language gets a bit confusing around that, and I have some slides that might help disambiguate some of that. Gender expression then is how people present themselves to other folks, whether they present masculinely or femininely, and that can change within a context. So for example, for myself as a trans man, when I was presenting as a butch lesbian, my gender expression was considered more masculine. But now as a trans man, if my gender identity is more masculine, then a lot of people read me as more feminine. So it's changed just because of my positionality in terms of what I call myself and how others interpret that. So that's that interplay of gender identity in terms of how we're interpreted socially. And so as you can imagine, that is critical learning in terms of how healthcare providers relate with the clients that they're seeing, and in terms of making presumptions and having stigmas and addressing their own, reflecting on their own stigmas and biases in terms of how people should present and what a man looks like and what a woman looks like and how they interact with the world. And then sexuality has more to do with who a person is physically attracted to or emotionally attracted to. And those two can differ as well, which can be confusing for some young people. If they're physically attracted to certain people and emotionally attracted and want long-term relationships with other people. And for all people, I guess, not just young people. I'm biased. My household also includes a child and youth psychiatrist, so I hear different stories. And that too can then change. A person who's trans might be considered heterosexual if their gender identity is female and they're attracted to people who are typically more masculine or male. They might call themselves a heterosexual, even depending if the anatomy of that person doesn't necessarily fit what we would call male or female. So some of that language can be confusing depending on, and so what you need to do is ask questions, which is the humility part of this conversation, being humble and saying, I don't know, and you're the expert in your experience, so I need to ask you questions. So the common acronym, and this one's taken right from CAHR with one modification, Canadian Institutes of Health Research. I took the TwoSpirit, and as is the common thing now, is to put TwoSpirit at the front and prioritize so that we're thinking First Nations immediately. It's not tagged on to the end. So TwoSpirit is in the middle between sexual orientation and gender identity because it's bigger and broader than just those two categorizations. And like much First Nations, Métis and Inuit ideologies, it transcends categorization. It's not categorical. It's all-encompassing in a worldview. And so it includes social roles. It includes often in many cultures, both pre-colonially and through colonialism, special roles for trans folk or for Two-Spirit folks who may be trans, or it may be a sexual orientation thing, or in our categorization. But in a lot of First Nations cultures, it's different and bigger. And the others, I think, are mostly pretty self-explanatory. Lesbian is a woman who, identified woman, whether she's a trans woman or a cis woman who's attracted to other women. Gay is a cis or trans man who's attracted to other men. Bisexual, somebody who's attracted to both men and women. Queer is kind of an umbrella term for all of those. Trans and transgender I've mentioned, and intersex I've mentioned. So TwoSpirit, just to flesh this out a little bit, was developed by First Nations people to describe their experiences and connect with traditions at a conference in Winnipeg. So as you can imagine, in the colonial period, a lot of this stuff was really stigmatized by the church and school and healthcare systems that moved, and fur trade systems that moved through Canada and colonized Canada. So this was brought back up in Winnipeg. It was meant to be a placeholder till they could find a more niche-y thing that fit better, but it's really stuck, and it seems to work. It's regional to our area, meaning it's an Anishinaabewin word meaning two spirits. And as I mentioned, it can encompass all of these different roles and communities. And then there's a whole myriad of other words, which are really small on this slide, I'm sorry. But cisgender, as I mentioned, gender fluid. So some people's gender identity changes quite a lot, especially as they're figuring it out. Gender diverse, similarly, can be that umbrella term. Non-binary, some people don't identify as either gender. Some people call themselves agender and are just like, these social constructs are for the birds, I'm throwing them out, and will call themselves agender. Asexual, some people don't have any sexual or emotional attractions and aren't interested in that. So they'll present as asexual. And then pansexual is another term that's very similar to bisexual, but it's trying to get rid of that binary kind of idea of that bi, I'm attracted to men or women. They could be attracted to non-binary people or trans people. And so it's a bit more of a political word. And then in terms of trans folks, there's been some changes through the years. You might hear older clients still call themselves transsexual. And in a lot of older clinicians will use male to female or female to male and use that acronym, the FTM and MTF. But these emphasize the sex at birth rather than the person's gender. As well, we don't call it a sex change operation anymore, or it's a gender-affirming surgeries, because you're affirming the gender that that person's feeling in themselves, as well as gender-affirming hormone treatment. And then trans male, so a person who is assigned female at birth, but their gender identity is male, and trans female, person assigned male at birth, but their gender identity is female. But really, at the end of the day, as I mentioned, like, it's less important to know all these labels, but then to listen to the person who's sitting across from you. And so this was a quote from a school-age client who was asked what gender meant for them, and they said it's way down deep where the music plays, which usually resonates with people because, I mean, how did you know if you were a boy or a girl? And lots of folks will just say, well, I just knew. And it's true for trans and non-binary people too, but the difficulty is you have all these social messages that boys like blue and girls like pink, and boys like roughhousing and girls, should be quiet and helpful and all of that sort of stuff that are kind of playing against maybe who you're connecting with and what you're working through. And sometimes when kids express those things, they receive punishment for that, or they're really challenged in that in a way that's maybe not super developmentally appropriate, but a lot of parents and caregivers don't know how to handle that. There's really good resources out there on what to do with some of that, but the research is still young. So some of the things that we as clinicians can do are using people's names that they tell you. So for example, it's really common with cisgender and heterosexual clients that I've worked with in the hospital for somebody to say, oh yeah, like I check their name bracelet against their medical record and it's, Robert Edward. And they say, well, my parents called me Ted, but all my friends and family call me Bud. I wish you called me Bud. Okay, I'll call you Bud. And I might chart in my note, Mr. So-and-so goes by Bud. This chart note will use Bud throughout. And then I can chart with Bud. I've clarified, this is the patient I'm talking about. I'm going to use Bud. This is what this person goes by. And so we do this with our clients elsewise, but sometimes in the trans world, people get kind of stuck on using a bit of the power play to say, well, I have to use your legal name in certain situations, and then are misnaming or misgendering people and using different pronouns. And in terms of degendering language, a lot of us who stand in the front of classrooms and things can use really good examples, like instead of calling the class to order by saying, ladies and gentlemen, or hey guys, come on, let's bring it together, can start with like, hello everyone, good morning everybody, just using collective words that encompass everybody, right? So students may or may not pick up on some of that, But the ones who need to pick up on it, the ones who feel excluded, are the ones who are going to really pick up on that. Others may not, unless you draw their attention to them. And it's becoming more institutionalized. As you can see here, the APA style guide, the one that's coming out, it includes a singular they, which Shakespeare used. It's been around since the 1300s. So anyone who says it's not grammatical, it's like, yeah, it's not Victorianly grammatical, but don't worry, we're not Victorians, we can move on. So why is this stuff so important? Why do we need to make sure that those ones who are picking up on the everybody's are picking up on it? It's because some of the numbers are just frankly staggering. For example, half of trans men and women in a Canadian study, it was Ontario, Trans Pulse Ontario study, reported trans-specific negative experiences in the emergency department. 1/5 reported avoiding going to the emergency department when they needed care because they were concerned it might negatively affect their experience. And so one slide that I often read at this point in talks is from the Globe and Mail, and it's a trans woman who wrote in about her experience at downtown Toronto. So you'd think, inclusive, friendly urban environments are friendlier to gay and queer people, trans folks. And the nurse in the emergency department read the person as trans immediately. It's trans woman, so a lot of trans women have those secondary sex characteristics like an Adam's apple and large hands and things that allow people to, and maybe their voice, especially if they're sick. This person had Crohn's and was in a lot of pain. And it allows people to sort of read them as trans. A lot of trans men, can pass a lot more easily if they've been taking hormones for a while and sort of fly under the radar. So this trans woman was read as trans, and the nurse went back in their health record past 2 years to find out what their birth name had been, and then insisted on using their birth name and he and him, and then mocked this patient in front of the paramedics. And you can find this online, and I often read it, especially for undergraduate students, because it's so shockingly appalling. And this is my profession in a national newspaper and a patient's experience of their care in the healthcare system in 2018. So it's not like I had to dig this up from, 1990 something. So those kind of experiences can lead people to not seek healthcare when they need it. They have double the risk of exposure to traumatic experiences just generally, and are more likely to be homeless. LGBT youth are more likely to be homeless, more likely to use substances. 77% of trans adults have seriously considered suicide. 50% of those, it was because they were trans. 43 have attempted suicide in their lifetime. And so those numbers are also from the Trans Health Ontario study. Of that group, so that's staggering. That's just shocking relative to the general population. Just far and above, I think, of the general population, 3% have attempted suicide in their lifetime, and 11% have ever considered suicide. So 7 times more. In that group, trans youth were twice as likely to have considered suicide than their cisgendered peers, and than their trans adult peers, and 3 times as likely to have attempted in the last year. And so James Makosis was here speaking earlier this month. He's a Cree TwoSpirit doctor out in Alberta. And he basically said he got into trans health because he wanted to save lives. So he does primary care to save lives. And it's accurate. It's what he's doing. So, and just some more stats that compare that one from the US. So, but if trans youth have supports, so if they have a low rejection family, somebody who's in a family who doesn't reject them, basically, or somebody who's in a family who does reject them is 8.5 times more likely in terms of suicide attempts. So I don't like this graphic, always confuses me, but yes. And so that there's other literature to support too, that trans youth feel much more supported if they even have just one supportive adult in their life, whether it's a teacher, a mentor, a healthcare provider, that kind of thing. So those little things of people introducing themselves as, hi, I'm Benjamin, I'm your nurse today, my pronouns are he and him. And then their parent going, why would you even need to tell me your pronouns? Well, because it's just a thing we do. And then that teenager who's sitting there listening to them, or that 9-year-old who's listening to them is thinking, oh man, okay, maybe there are people who move through the world a little differently than my family. Like maybe some of this stuff I'm thinking I'm not alone and I'm not that weird. And so these gender transition steps are primary care, full stop. There's been a lot of push in the past for people to move trans folks into refer to endocrine specialties and you have to refer to surgical specialties. But a lot of the basic care, first off, their basic medical care is primary care, easy. But transition-related care, including the hormone therapy, can be done by nurse practitioners and family physicians, no problem. There's guidelines to follow, and there's training, there's education through Rainbow Health Ontario for people to be able to do that and to be able to refer people to trans-related surgery. You don't have to have a psychiatric diagnosis anymore for gender transition, which used to be the thing. And you used to have to live for a year or two, depending on your jurisdiction, as the gender you wished to transition to, and therefore had to pass. And you had to, I don't know, live up to somebody's standard of what male or female looked like, oftentimes the doctor. And if you weren't doing that successfully, you may or may not be then allowed to go on hormones or allowed to go on to have surgery. There's also psychosocial transition, which people need support, so telling their families and coming out, as well as legal transition, so changing your paperwork and documentation. And so knowing the resources that can help people with that are really imperative. And so often in urban centers like in Ottawa, I'd know who to send to. In Kingston, I'd probably know who to send somebody to. In Toronto, I'd have a good idea of where to start looking anyway. So cultural humility, that thing that brought us here today, just health education programs in the world over are lacking in content regarding gender minority populations. And this results in trans folks reporting that they have to teach their healthcare provider about trans issues. And cultural humility, though, is this broader notion that if somebody came to a healthcare provider saying, this is my concern, the healthcare provider would say, okay, I don't know a whole lot about that. I don't need you to teach me. I just need you to tell me what you need from me today. And then I need to go read up on that. And we need to make a plan for your next visit so that we can figure out how we can work on this together. So I don't know that individual situation. So all of the intersections that they might have in terms of culture, like in terms of ethnicity and race, in terms of their sexuality, their gender, you need to ask some of those questions. I need to challenge my own assumptions and be self-critiquing. In the past, in my education, cultural competence was very, very big in the late 90s and early O's. And at that time, it meant general facts. I know general facts about group differences, and I can improve outcomes. So we were given lists in our nursing textbooks that, certain people like to have hot water, and these people don't like eye contact, and this, that, and the other thing. Well, if somebody's a first generation person who maybe likes hot water, that's great, but their kids might have grown up in Canada and would prefer ice water in the morning, thank you very much, so don't bring me a cup of hot water. These lists only work for certain individuals, usually the norm of that group, and not the outliers. You're only going to know what your patient needs or wants if you ask them. So cultural competence in the literature has kind of moved towards being more inclusive and looking a lot more like cultural humility. But the philosophical underpinnings of it and the language around it still includes things like competence and categorizing and being really structured and here are outcomes. And so with that language, if somebody says they're competent, then they often feel like, I don't need to learn more. I'm competent in trans health, or I'm competent in queer health. And that might not be the case. Way back, cultural sensitivity and cultural awareness were kind of the things. I should consider client differences, or I should just be aware that people are different. Very good. Yes, you should. And so really moving up this scale, that line there is meant to indicate a bit of a transition in where the focus is. So I think cultural humility is the responsibility of the healthcare provider to be humble. I don't know what your situation is. I need to ask you questions to understand you. Cultural safety is something you build with the client or the population or the family. And it's it's a systems outcome, that you're recognizing the power imbalances, either because you're a healthcare provider, you're able to recognize the structural imbalances that might affect that person, some of the barriers they might not be aware of. They're able to tell you about barriers that you're not aware of from their point of view. And so it's an interactional relationship that's framed in that culturally humble approach of the provider, which I think is critical for our learners and us as practitioners to be able to do. And so it's based in this theoretical framework. This model is from Fronda and others who are, it's a nursing model, but it's based in the medical cultural humility framework, which was a seminal article by Tervalon and Murray Garcia in 1998. And so Fronda and others didn't include that paper because of their exclusion criteria for doing this concept analysis that they did, which is really unfortunate because the one key part of their model that's missing is that systems critique that is embedded and interwoven throughout that original seminal article and didn't get carried forward into this nursing model. And I think nurses are uniquely positioned to really be critics of healthcare structures because they see so intimately the interactions of all the team members, all of the systems on their patients and families and populations. And I think it's a framework that works for all the people on that interdisciplinary team as well. And so it's that interaction between people. The cultural humility components include openness, self-awareness, egolessness. So I don't know everything just because I'm the provider. You're an expert in yourself or your family. That supportive interaction and that critical self-reflection. And then it includes lifelong learning, which has empowerment, mutual benefit, respect, partnerships, optimal care. All of them are happening in an environment of diversity and this environment of power imbalance. So for example, in that hospital example that I mentioned from the Globe and Mail, that nurse, that person with Crohn's disease, trans woman with Crohn's disease, needed to play along with that nurse who was being so disparaging because they needed pain medication and they needed to see the doctor. So they needed to get past this intake nurse that was getting handover from the paramedics. So she had a lot of power in that situation, not only because she was a gatekeeper, but she was relying on the paramedics to be on her team because they were part of the structure. And she was wielding that power. And they were admittedly uncomfortable, but they also weren't in a position to stand up for that trans woman either. They didn't want to make waves. They needed to get their bus back out on the road, and they needed that nurse to move this person on to the physician as well, right? So that person held a lot of power in that situation and was wielding it like a club. And I think we need to recognize when we do that in our healthcare systems and be reflective. I mean, I wish it was because it was the worst story I've ever heard. But my lit review for one of my courses was all on qualitative people's experiences with their primary practitioners. And it was people mostly in North America and Europe, where a lot of this is more accepted in society. But the stories throughout the qualitative research, some of it's, minor, but that whole idea of the minority stress model with the idea of like 1 or 2 mosquito bites are annoying. But if you get all the mosquito bites all the time, your whole body is going to have an inflammatory response, right? So people moving through a healthcare system that insists on people wearing pink bracelets if their healthcare card has a particular letter on it, then are getting misgendered all the way through the system. It's like mosquito bite after mosquito bite after mosquito bite after mosquito bite. So those minor little bits and pieces that we think, that's so annoying. Yes, but if you're having to out yourself all the time in every conversation and correct people all the time, like it's easy. It's very common for people to make mistakes, and I don't want people to feel really self-conscious that, oh my gosh, what if I misgender somebody? You apologize and you carry on. The worst thing to do if you misgender or misname somebody, it's so easy to do, and I do it with my own signature. I have scripts, internalized scripts. I did it the other night on the phone with my mom. And I was like, hi, Mom, it's me. And I almost said, like, my other name. And she's like, it's hard, isn't it? I'm like, I know. Don't worry. I get it. It's hard. Because it's a script for me. I've been saying it for 40 plus years, right? Whenever I talk on the phone. It's so, the thing not to do, though, that makes it more difficult is, oh my gosh, I'm so sorry. Oh my God, I can't believe I just did that. Oh, can you ever forgive me? That must feel horrible. And then that flips to the person, the client having to comfort you in that moment. That's not your moment, right? Like, yes, it's unfortunate, it's upsetting, but you can compartmentalize that and deal with it. We all make mistakes, and it don't worry, like, and I'm really sorry, and just carry on. Sorry, I'll try not to do that. Please help me if you hear me and I wasn't aware. Another way to introduce it is to use a like oops or ouch approach. So I do this sometimes with undergraduate students if I have a small enough group. If somebody says something that's kind of not inclusive or kind of makes somebody else's hairs on the back of their neck stand up because that just isn't what relates for them, somebody can say oops or ouch, and then they can just pause the conversation and say, you know, when you described nursing and you said the nurse was she and the doctor was he, I find that really uncomfortable. Can we use more inclusive language? And just oops and ouch it. And then it's not a, oh my gosh, you've paternalized the whole profession. This is a big deal. It's just, let's pause for a second and think about how not all doctors are men and not all nurses are women. And maybe we should say they, right? The nurse, they did this, and the doctor, they did this, right? So those kind of considerations. I'm sorry, that kind of went on a little from your thing, but I think that story is so monumental. It's not unique, but also the minor things aren't so minor because there's a lot of them. And it applies for race, and it applies for ethnicity and socioeconomic status and all sorts of things where we don't necessarily think about people who are outside the norm in our care. So implementing this into health curricula and research. So coming soon, collaborating on an awesome team of folks. 3 of us were funded through CIHR for a trainee award looking at 2S LGBTQI knowledge translation. And we've teamed with CanSim here at Queen's, or based out of Queen's. And so 3 folks there who make these really awesome videos. And so we have one here, and I can show you. So there's our development team for this particular script, including Marion Lechterflaut and Jane Tierman and myself, and our actor and Dane Woodland, who was in Newfoundland, helping us write the script as well. So this is an interactive game. Basically, it's a choose-your-own-adventure type game where you see video vignettes of the case scenario and the patient and the healthcare provider. And after each little video segment, you're asked, what should the provider do in this moment? And then given some options. And if you click the wrong option, you see the consequence of that action. And if you click the correct answer, you see the consequence of that action. If you get the wrong answer, you get the consequence and you get looped back to your choice until you find the right answer. And then you carry on through the game. There's an accessibility statement here. And so in the scenario, it's a person named Cody, whose birth name is Casey. So there's a few things around introductions and using the right name. And this young person, it moves through using the HEADS assessment. So it stands for home, education. It's used in emergency departments and for working with youth in assessing sort of their key social environment stressors and what could be at play for them. So it moves through a HEADS assessment, asking them about their different social relationships. Oh, there we go. Who presents to the emergency department with feelings of acute anxiety. He's being bullied at school, and the situation has recently escalated to an acute crisis, and he's requesting something to help with his anxiety and access to trans youth resources. So this young person isn't out to his family, and recently there's been a social drama in his high school that he explains in the video.
Hi, my name is Michelle. I'm your nurse today. You're Casey, correct?
Actually, my name is Cody.
So he said, actually, my name is Cody. So what action should the nurse take in response to the patient's statement? So they should use the legal name in talking to them and chart the legal name they should use the stated name Cody and chart the stated name Cody, or use the stated name Cody and then chart the legal name Cassie. So I don't know if people want to take a guess. You don't have to hold your fingers up. You can hold it up by your chest. But if we choose, say this one.
Okay, no problem. I'll just chart Cody when I document everything.
It's not the best choice. A clarifying statement is needed in the documentation to align the legal name of the person to the individual you're charting. So correct that grammar error and get that link in there at some point, but returns you to the option. So if you choose this option.
Thanks for clarifying. Yeah, we can use Cody, but I want you to know that I do have to chart a statement about your birth name until you pursue a legal name change. Have you done that yet?
No.
Okay. So what I can also do is highlight on the chart that you prefer to be addressed by Cody so people know how to address you. Does this sound okay for you?
I'd appreciate that. Thanks. I don't usually get that response.
So then how would you like to be addressed, and what name and pronoun would you prefer? Facilitates an open and trusting relationship. You can clarify legal name at the beginning of your documentation and then use preferred identifiers throughout your documentation, just like you do with any other client who uses a nickname or a middle name or goes by junior or some other title, that kind of thing.
So, by the way, my pronouns are she and her. What pronouns do you use?
I use he and him. Thanks for asking.
Of course, I can flag this on your chart and let us know if anything changes. So, can you tell me what brought you in today?
Things are really bad at school, and everything is falling apart. I have this friend who I thought I could trust. We hooked up last night, and it was kind of uncomfortable and weird. And then I get to school, and everyone knows. They were whispering and laughing and mocking me. My parents don't even know. If they find out, they will kick me out. They don't understand.
So, well, how does this make you feel?
At first I was just so mad, and I felt out of control anger and ended up smashing my phone. I just wanted to hurt him. I'm so alone. No one seems to understand. Everyone is against me. I'm losing everything. I just want this nightmare to end. I need a minute. Where's the bathroom?
So how should the nurse best respond? Provide directions to both the men's and women's bathrooms, provide directions to the men's bathroom, provide directions to the women's bathroom. So I'll just click on this one here first. Move along here for a sec.
Absolutely. There's a men's bathroom down the hall on the left and the women's just right across the hallway on the right. And there's also a private bathroom on this side of the hallway.
Okay, can I use any of them?
Whatever makes you feel most comfortable. And let me know if anyone gives you a hard time about this and I'll help you out.
Right, so the bathroom thing is a hot button issue in a lot of newspapers in the US a couple years ago. Because people were passing bathroom bills or trying to pass. None of them passed, by the way. None of the bathroom bills in the US that you may have heard about ever passed. About preventing people from using washrooms and locker rooms based on their identity, sex assigned at birth. And trans folks may or may not use a particular bathroom based on the circumstances around where they are and how they feel in that moment. They may have somebody might have seen somebody they know going into a particular washroom that they're not out to, so they might use a washroom that you as the healthcare provider know that they don't typically do, or they might have had an experience at that particular setting in the past that makes them uncomfortable doing that again. So providing all of the option provides autonomy to the person to make their decision for themselves, and this nurse demonstrates being a supporter. And so this is the kind of thing, it moves on to deal more with Cody's situation. And I'll leave it in suspense so that you can see it when we finally have it out to everyone. Just in closing, all of the bits and pieces of that cultural humility model, including the missing piece of critiquing structural the structures is included in all of health sciences at Queen's, all of our different schools, new graduate competencies. So our medical students, every single one of these lists, including professional that got cut off here, medical expert, communicator, collaborator, leader, health advocate, scholar, and professional, include elements that are from the cultural humility model. All of the things in the National Nursing Education Framework at the undergraduate, master's, and PhD level, all of the different subsections of that, including, of course, the subsection that includes cultural safety as an outcome for our nurses at all the levels, is in the framework. Cultural humility is represented in all of the physiotherapy competencies that we expect our new graduates to have, and it's included in all of the occupational therapy competencies that we expect our new grads to have. And so it's important because it's also included in the Truth and Reconciliation Commission for closing those health outcomes for First Nations people. It leads to cultural safety. This needs to be a priority in Canada, and we need to make sure that our healthcare providers are thinking not only of First Nations, but those TwoSpirit folks then who fall outside the norm within this community that's already outside the norm of Canada. And just to represent that, TwoSpirit people aren't included in the Tri-Council policy, even though it includes First Nation people and it includes gender analysis of research, but it's binary. They're not included in the Assembly of First Nations ethics in First Nations research, and they're not included in the newly released CPATH trans ethics guidelines for working with trans folks in research either. So a perfect example of intersectionality and how a population that's on the outsides of a population that's already on the outsides falls through the gaps. So that's why I think cultural humility is just so important, and why I appreciate you having me here to tell you about it today. So, thank you.
Thank you, and thank you for, I really appreciate it. All the frameworks that you presented today, especially in terms of cultural humility and how in the past the language we've used was cultural competence. And I've always struggled with that personally because, I mean, can we truly become competent? Right. And is that the desirable outcome? Or is it more curious and aware and celebrating?
What's interesting about that is that language matters. And I think that's a common thread that Ben has woven through this presentation and through his research as well. Mm-hmm. Language matters. Absolutely. And if we say we're competent, it's almost sets up a paternalism that I think can be difficult to overcome. Mm-hmm.